Thanks for joining our Q&A session today. I'm Mo. We've got Professor Neuberger with us today as well. How are you doing, Professor?
Good, thank you. And you?
Very well, thank you. Yeah. Before we start, I just want to take the opportunity to remember for our patients that these Q&As don't take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. Also, please just be mindful that Facebook is a public forum as well, and for more privacy, you can join us here in the room on Click Meeting. So I'll get started with the questions that we've had sent in, and I'll also keep an eye in the chat for any questions that are coming in live. We do have a lot of questions on our list today because a few of our Q&As recently have been some specials with regard to the OCA situation. So we've got quite a healthy list of questions to get through today. So we'll get started on that. So our first one is from a patient who's wondering if you could please advise on the process for diagnosing PBC. They've had some blood tests done back in February that showed they had a strongly positive AMA and a positive result for anti-RO52. They were referred to rheumatology by their GP, but still waiting on a confirmation letter, so they got themselves referred privately. The consultant said that the results indicate that I may have PBC and said that I needed to be referred to hepatology. I've since spoken to my GP and asked if I could have a liver scan to see if it is PBC, but they've said that they need to refer me for a liver scan and only the consultant can do that. The wait for their gastroenterologist is anything up to eight months in their area at the moment, and they were just wondering if there was anything else they could do, as they're now worried and conscious that any delay could be damaging if they do indeed have PBC. I thought this was quite a good one in general as well, just to go over the diagnosis process for anyone who's new and what to expect.
Right. The diagnosis of PBC is normally made on a number of different criteria. The first is the positive antimitochondrial antibody at a sufficient concentration. So normally it's 1 in 40, which is just a way that it's usually or often detected using a process called immunofluorescence. You dilute the serum sequentially, and a titer of over 1 in 40 is highly suggestive of PBC. Compatible liver tests, again with the raised alk phosphatase, although do be aware that some people with PBC do not have antimitochondrial and AMA detectable at diagnosis, and some of them never develop detectable antimitochondrial antibodies, but there are other less common autoantibodies that are specific to PBC. The liver test, which show raised alkaline phosphatase predominantly, again, is not specific to PBC. And then, of course, there are the symptoms. Those of you who are long in the tooth with PBC will notice I did not put in liver histology, or liver histology is what you get from liver biopsy. This is because if you have a compatible history and symptoms, abnormal liver tests and antimitochondrial antibodies, there is no need to do a liver biopsy to get confirmation. There are very few number of people with whom you can't make the diagnosis any other way than with histology, doing a liver biopsy, but they're very much the exception. We used to do some liver biopsies, not a huge amount, but now we do far fewer for the diagnosis. One question is, if you have antimitochondrial antibodies and are asymptomatic and with normal liver test, is this PBC? There's a great deal of debate about that at the moment. There has been, and I think will remain so. Many people will go on to get PBC, but whether that means you have PBC or will get it, I think is a matter of semantics as much as anything. So the diagnosis of PBC is made predominantly on the history. Have you got the right background? Are there other factors which could confuse the situation? Do you have abnormal liver tests? Do you have antimitochondrial or the other PBC-specific autoantibodies? The role of liver imaging, whether it's by ultrasound or FibroScan, is separate. Normally, people with PBC have a slightly enlarged liver, but it's not invariable. And the the imaging will not, the ultrasound will not make or refute the diagnosis of PBC. It will look for the shape of the liver, what the liver substance looks like. You can look at the gallbladder, how big it is, or whether it's shrunken, whether they're gallstones, whether there's abnormality in the blood vessels or the bile ducts. So you do an ultrasound for various reasons, but not to make the diagnosis of PBC. The other form of imaging is with a fiber scan, which will tell you two other things. That gives you a measure of both the amount of scarring, if any, in the liver and the amount of fat in the liver. But again, it will not tell you whether or not you have PBC. That is done on the blood tests primarily and the symptoms. Does a delay make a difference? Well, I think the rheumatologist was very correct in saying he thinks or she thinks this is probably PBC and you're better off under a hepatologist. And I think the rheumatologist did you a service there, because there's a lot to PBC, as you'll know from all the information the foundation gives out. And you want to have somebody who can give you the information, offer you the right treatment. The delay is frustrating. Yes, if you have PBC and it's appropriate, you may well be suitable for URSO, and the sooner you get on with that, the better. But the reality is that the need to get on with it is more psychological, if you will, than physical, because people have PBC usually for many months or years before diagnosis, and a few weeks here or there doesn't make any overall difference to the outcome. Of course, it's natural you want to get a diagnosis, then you can start to come to terms with it, you can start treatment if it's appropriate, and so there is that urgency. And but in terms of the overall natural history, usually, and I say usually, a delay in a few weeks or months doesn't make much difference. But clearly from the mental health point of view, which is just as important, if not more important, you want to get on with it, because whether the diagnosis is PBC or in many other cases with other diagnoses, once you know what you're dealing with, you can start to get your head around it. But when you don't know, when there are questions, that's when it's really tough for you and your family. So I hope that answers all the points of the question.
Yeah, I think it does. I would just say to that patient as well, as I appreciate whilst you're waiting, that can be worrying. If you'd like to have a chat in a bit more detail, please just give us a call on the helpline and we'll do what we can as well, and chat that through with you. So moving on to our next question, we've got a patient who's had an endoscopy recently and since then been experiencing the same pain I had after a liver biopsy, which is feeling like I've been punched in the ribs. I have checked with a gastroenterologist who says the procedure went normally and I should go and see my GP if in pain. Does the pain reflect inflammation of the liver or anything else I should be aware of?
It's always important to take pain seriously. It's a useful sign. Whether it's related to the endoscopy, whether it's diagnostic or therapeutic endoscopy, how long the interval was and so on is all relevant. People can have pain in association with PBC. I think that's well described, and it functions to various people differently. I think when people have pain that persists and is unexplained, then you do want to see your GP, who can take a proper history, know where the pain is, what brings it on, what relieves it, and all the rest of it, what type of pain, and can also examine you if that's appropriate. Because again, it may well be nothing that requires treatment, but until you've had somebody competent to take a history to examine you, there's always the uncertainty. So as I say, if it follows the endoscopy, yes, it could be related, I suppose. There are a number of things. I would not put it down to anything specific until I'd taken full history and perhaps an examination as well. So go, if it persists and it's causing problems, go and see your GP, get them to have a look, and then hopefully reassure you. The severity of the pain and the severity of the symptoms don't match. You can have quite severe pain and just pull the muscle. Doesn't make the pain any less, but there's no adverse significance. But if in doubt, go and talk to your GP, get them to have a look and make the diagnosis.
That's great, thank you. There's a question, just as we're talking about pain there, there's a question came in live there around bone and muscle pain and taking medication for that and whether or not it's a good idea. I just wanted to say, I'm happy if you want to say something else, Professor, but we've done quite an extensive Q&A on pain. You did that for us before, and we've popped that up onto our YouTube channel as well. So where you went into quite considerable detail around the different types of pain medication and when to think about using one and a different one. Is there anything else that you would want to add to that? It's just a patient asking about bone and muscle pain and drugs, and obviously they're asking if it's a good idea, but if I remember right from our previous chat, it was, pain needs to be dealt with if it can be.
Yeah, the important thing, why have you got the pain? And again, for muscle pain, there are many causes, some of which require treatment, specifically others of which don't, is which muscles are affected, if it's the bone pain. So you want to know more about the pain, what the cause of the pain is, and then treat it appropriately.
Great, thank you. So we have a question. My wife was diagnosed with PBC some 22 years ago, and her LFTs are showing stable. In the last 5 or 6 years, she's developed a chronic cough with a heavy production of mucus and sticky saliva, particularly in the evening and at night time. She's had x-rays which has ruled out lung problems, but this overproduction of mucus and sticky saliva is getting worse. Could this be connected to her PBC?
Not that I'm aware of. That doesn't mean it's not, but I'm not aware of it. You do get some lung conditions associated with PBC, particular fibrosing alveolitis, for example. But I think if you're having a problem that's persisting, and if you go and talk to your GP, if it's causing problems and you're worried, then consider asking for a specialist referral, but don't put it down to the PBC.
Thank you. We've got a patient who's 69 with PBC, AMA M2 positive with an ALP of 140. All other liver tests are normal and they're on urso. Their LDL is 4.5, HDL 1.4, triglycerides 1.32, overall number 6.5. They've tried, my pronunciation might not be right, they've tried atorvastatin and rovastatin, but all seem to give headaches and muscle aches after a few weeks of taking. No high blood pressure and not overweight. Their Q-risk score is just over 10. Is statins a good idea at this point, and any other advice?
Right. Just a little bit about cholesterol. When I was a houseman, cholesterol was very easy. You just measured the total cholesterol, and if it was high, diet was probably the only treatment. That's pretty ineffective in reducing it. It'll reduce it a little bit, and the only thing Benecol or these ones will do is sort of affect your grocery bills. Diet is not a very effective way of reducing cholesterol. Now people are a lot more sophisticated, and they're measuring subclasses of cholesterol, and HDL, which is good cholesterol, LDL, which is bad cholesterol. And so for the majority of people without PBC, the way in which you manage high cholesterol is fairly well established, evidence-based, and statins are the go-to drugs in the first place. They do have side effects like all other drugs, but PBC is slightly different because people with PBC tend to have an increased cholesterol from a version called lipoprotein X, and that elevates your total cholesterol. And we know from numerous studies in the UK and elsewhere that people with PBC do not have an increased risk of cardiovascular, of heart attacks or strokes. So the algorithms that normally apply to the non-PBC people have got to be slightly cautiously dealt with in those with PBC, because you get a falsely high cholesterol. So I think the first thing that your doctors need to discuss with you is whether you need treatment. Treatment, yes, has benefits, it has side effects, and obviously the statins you've tried have given side effects. The treatment whether your doctor advises treatment will also depend on other factors such as family history, other medical conditions, and so forth. So it's not quite as straightforward as it might seem. If treatment is necessary, then statins are usually, for most people, the first line treatment. There are a number of different statins. They're basically, it's rather like different types of vacuum cleaners. They all basically do the same thing, but have different strengths and weaknesses. If you get side effects from the class, so sometimes you can get it from one form of statin and not from another, and clearly your doctor's tried you on different ones. If they think it's a reaction to statins as a whole, there are other drugs like ezetimibe and so on that you could try. Discuss that with your GP. So 2 stages really. One is treatment appropriate for you? The second thing is what treatment? And that may be statins, but if you're getting side effects, then there are other options. So talk to your GP and see what there is. Yes, they do have different side effects, but the thing about the cholesterol is doesn't give you any symptoms until you have your complications from it, like strokes and heart attacks. So you don't want to have a treatment that gives you side effects. So those are the 2 stages. And if statins aren't going to be for you, talk to your GP about other options. And there are several other groups of drugs that are worth considering if your GP thinks it's advisable.
Great, thank you. We've got a couple of questions around weight loss, and also there's one came in live as well around this. So the first one is a patient who's been recently diagnosed with PBC and they're overweight, and they're asking, is it okay to do intermittent fasting? Yes,
I think losing weight is a real challenge for most of us in society. And the thing about diets, we've talked about this before, is that diets usually are a short-term fix. They're often very effective, whether it's intermittent fasting, whether it's 3 to 5 or whatever. But the real solution, I think, is to focus on changing your habits so that you're cutting out eating between, what usually gets people is cutting out, it's eating between meals. You can help very easily by going for low calorie things. I'm always surprised when I go to the shops and seeing people buy, for example, full sugar Coca-Cola when they're overweight, because you think, why don't they just go for low sugar? It's slightly cheaper. So changing how you eat and eating less. Some people find diets of different sorts very helpful. I think whether it's safe will depend very much on the stage of your PBC and any other medical conditions that you might have. So you've got to be cautious. People will be aware very much of the various treatments now that are available, the pharmacological treatments for helping you lose weight, and there are a number of different approaches, and semaglutide, and again,
that's our next question. Yeah,
is one. A number of things to say about that. Though semaglutide is comparable, and there are several comparable drugs, can be very effective in helping you lose weight. They should be seen as an aid to losing weight, not an alternative. So you don't have your semaglutide and then 3 large cream cakes. You probably wouldn't want to. They are not without side effects, and the manufacturers warn against use in liver impairment. So they do have other side effects as well. They can interact with other medication. So you have to use them with medical support, making sure that it's safe for you and it's not going to have an excessive risk. And of course, there are risks with semaglutide as there are with other drugs. You can get them online, as you know, and there is a real worry and evidence that people are putting online drugs that they claim to be semaglutide or similar, and they're not, and they're dangerous. So I can understand the temptation to go online, get the semaglutide or equivalent, and help you lose weight that way. Don't. Go to your doctor, seek their advice, make sure if it's safe for you. And again, it may be, but you have to be cautious. Again, intermittent fasting may be safe, but just check with your GP or your hepatologist. What do you mean, and again, people have different regimens, whether it's 2 days off or several hours off. They do work, but if you've got liver disease, you've got to be that much more cautious and careful. But drugs now are a lot better, but there's still no simple solution. But we're getting towards it, and it is difficult. If it were easy to lose weight, it's not just a matter of willpower. If it were, people would be a lot more successful. It's a way of changing your habits is the key thing, I think, to successful weight loss. Avoiding high-calorie foods, avoiding eating between meals, putting less on your plate, not standing by the buffet at meetings and when food is available, all those sort of things. It's changing your habits. But again, it's very easy for somebody to sit there and say that, and much harder to do. But to come back to the question, talk to your GP. I'm sorry, I'm always coming back to this because it's so individual.
Yeah.
And drugs can be of help, but in people with liver impairment, they've got to be used so much more cautiously because the side effects can be that much more severe.
Just a couple of follow-ups just based on the questions there. So one of the patient who had given us a question ahead of time, which was in the notes, the issue they're having is their GP is prepared to give them the injection, but their consultant at the hospital is not, and their GP is obviously looking for something to confirm that. Would you suggest that she goes back and discusses that with them again?
It's very difficult when you get confusing information. And there are many reasons why you might have confusing information. Sometimes it's ignorance on one party or another. Sometimes it's caution. But what you should do, particularly if your hepatologist is saying no, go and ask them why. Is it just caution? Is it evidence-based? Have they had experience of people who've had it and had severe reactions? So hepatologists will be very good at managing the PBC. They may know less about the drug interactions, but equally the GP will know probably more about the drugs, but less about the liver disease. But find out why, you have absolute right to challenge is a slightly aggressive way of putting it, but to ask, say, why are you against it? What are the risks? Because at the end of the day, you're the one with a problem. You're the one with the side effects. And for people to give informed consent, it's important. The doctor is not obliged to give you the drug just because you asked for it. If they think it's not in your interest, they have that absolute right to do that. but equally you have the right, and I would say responsibility, of checking with the doctor and say, why did they advise against it? And there may be very cogent reasons that the GP didn't know, or they may be just they're cautious and so on. So find out more, and then and try and do it in a non-aggressive way if you can, but be persistent and make sure you get the answers you want.
A term I use regularly, and I think it was my sister that gave it to me: politely persistent. That's what you have to be, politely persistent. Yeah. But yeah, and I think because it's not possible for us to say it's safe across the board for all patients, it really does need to be a discussion between their GP. So I hope that answers the questions that we've had both live and that we had sent in. If it doesn't and there's any further information, please just reach out to us on the helpline and we'll see what we can do. But thank you for that. That was really informative. So we've got a patient asking if PBC has any connection with bradycardia, as diagnosed with both illnesses at the same time.
The short answer is probably no. When I saw that question, the one thing that occurred to me possibly was if your thyroid is underactive, which it can be in association with PBC, you may have a slow heart rate. I suspect it was diagnosed coincidentally. Just because you have PBC doesn't mean you can't have other conditions. But again, I think one of the frustrations that I see, and I guess Mo sees also, is people attributing everything to PBC. You know, the dog had diarrhea on the carpet. Oh, that's your PBC type of thing. But I wouldn't put the bradycardia down to PBC or the PBC down to the bradycardia. Okay. Sorry, and for those who don't know, bradycardia means a slow heart rate, and equally tachycardia is a high heart rate. And technically, I think bradycardia should be below 40 beats a minute, and tachycardia should be 100, or above 100.
We've got a question around second line now. So I was diagnosed in 2020 and I've been taking Urso since then. Last year, my ALP started to rise again. It's never been lower than 180. All other tests are normal and the patient's lucky to be without any symptoms. On their last appointment, the consultant suggested they'd be an ideal candidate for second line treatment, and they've got a consultation soon regarding that. But they are concerned now that potentially that second line treatment would be OCA. And there's obviously been the news that from the EMA that they're looking at withdrawing the license for that. I'm not sure where this patient is based, so it might be worth just covering it from a European and a UK perspective.
Right, I suspect you're more up to date with the EMA than I am, Mo.
So what I would say to that is that the decision has not been, we have been protesting and we have put a petition in and wrote lots of emails from patients to the EC who are looking at the decision that was made by the EMA. And we're hoping to have an update on their decision soon. But what we've asked is that they ask the EMA to reconsider the decision on withdrawing it. The thing to point out is that there are no safety concerns around OCA. It's really the design of the trial that's failed. And that was that the trial post it being given its license, they asked for 5 further years where they would be placebo armed to that. But what happened, obviously, is once patients realised they weren't on OCA as part of the trial, they could then go to their doctor and be prescribed OCA. So that's what happened. Patients dropped out of the clinical trial and went and received OCA and got treatment that way. So it's due to a lack of information, not any safety concerns with OCA. So we've asked them to reconsider that and also look at real world data. There's no, as far as Europe goes, we don't know what's going to happen in terms of when the response will come back from them. And we still think that patients who are already on it will be able to continue, and there'll also be the special access availability of the drug via the company as well. So what I would say is if OCA is something that's going to be suggested as your second line, keep an eye on our website. We're updating our information on the position with that as it comes. So if there's any news on that, you'll see it on there. And also, if you wanted to discuss it before your next appointment, give us a ring on the helpline and we'll chat you through where we are with it at that time.
And just to add, perhaps the EMA doesn't apply to to Great Britain. It applies to Northern Ireland, but Great Britain, England, Ireland, Scotland have their own. So the MHRA will look at the licensing of the drugs, and NICE or equivalent in Scotland will look at the accessibility of the drugs on the NHS, and then it'll go down to the NHS. So it's a different system. As you know, there are other options for second line treatments as well, and they may be more appropriate for you. So what I would do is I would go in with an open mind, listen to what the medical advisors have to say to you and what they recommend. And as just to emphasize what Mo said, is that it is probable that if you're already on OCA when the license is, if the license were to be withdrawn, you could probably still access the drugs. It is uncertainty, and it is unfortunate. Nobody needs more uncertainty in their lives, particularly if you've got PBC. But listen to what they recommend. It may not be OCA, and the chances are that if EMA go ahead with the withdrawal of the license, and if the rest and Great Britain were to follow, that if you were on OCA and it worked well for you, you'd probably be able to have surety of supply. But there are a lot of probables in that. And I think, don't go too far ahead looking for problems. Wait till you see what they recommend, and take it and go with what's best at the time.
And we will continue to update on the situation with the EMA, but also as it moves into the UK process, and then also for the FDA as well. We'll continue to update patients on that, any information that we have. And if you'd like, as I say, if you'd like to chat about it specifically with regards to your direct care, please just give us a ring and we can have a chat on the helpline about that as well. Thank you. We've got a question. This is going to test my pronunciation. Just been diagnosed with PBC, and I would like to ask if there's a connection with ITP, immune
thrombocytopenia.
Yes, that. Go and just repeat that again for listeners so that they know what we're talking about.
Immune thrombocytopenia, or ITP, is a condition whereby it's another autoimmune type condition. You develop antibodies to your platelets, and say you have very low platelets. So it's related insofar as people with PBC are at greater risk of getting other autoimmune diseases, and ITP is in many cases one of those autoimmune diseases. So there's a common cause, but they're not related. Many people have ITP without PBC and vice versa. The other thing to remember with PBC is, as with any liver condition, as the scarring in the liver increases, you can get an enlarged spleen, and that will result in low platelets. So a low platelet count in people with PBC doesn't necessarily mean ITP. It could be because of the liver disease, and you see low platelets in many other forms of chronic advanced liver disease. So if it is a bona fide, so I don't know if any of you remember the Victoria Wood sketch about Finey Bodo, and I always have to think about bona fide or finding bone ever since then. She's put the jinx on me. So make sure it is proper ITP, because that has specific treatments, whereas a low platelet count associated with an enlarged spleen usually doesn't require treatment. But in good hands, the diagnosis is usually fairly clear. And if you have ITP, that needs its own treatment regimen. So in answer to the question, they're related insofar as they're all part of the autoimmune spectrum. And if you have the genes that predispose you to autoimmunity, you may get more than one autoimmune diseases if you're unlucky. Why those autoimmune diseases in particular, we don't know. Not yet, anyway.
Not yet. Yeah, we prefer that. Not yet. There's actually a follow-up question to that that's came in live. Should I worry that my platelets and white blood cell count seem to be getting lower? When I discussed this, I was told that they were right for me, but I'm worried that they seem to keep getting lower. And it says, I do have an enlarged spleen, and my liver function is finally normal. After 8 years, I'm on 3-line therapy and also have portal hypertension. I think the concern is that it is continuing to become lower.
Yeah, in general. So if you get fibrosis, scarring in the liver, the pressure in the portal vein, which is the vein that carries blood from the spleen and the bowel to the liver, the pressure builds up because the flow through it is restricted. And that leads to portal hypertension. It leads to varices, for which treatment is required. And it also leads to a large spleen. Now, the spleen has many functions, but it acts rather like a sponge. So it mops up the red cells, the white cells, and the platelets. And as a consequence, most people with enlarged spleens have low white count, low platelet count, and maybe a low red cell count. Usually it doesn't matter, because white cells anyway are short-lived. They only live, well, the neutrophils, which fight some of the infections, only live for a matter of hours in the blood. Red cells live for days, and platelets in between. So usually the consequence of the hypersplenism, as we call it, doesn't make any difference. You don't treat the low hemoglobin that results in the low red cells. There may be an increased propensity to infections because of the low white cells, although not as probably related in so much to the liver as to the spleen. And the low platelet count usually doesn't require treatment. It doesn't usually cause problems. Part of the reason is the bone marrow is making the platelets. And it is said, although I've not found this a problem, is that if you start bleeding, your spleen can constrict, and the platelets that are trapped in there go into the systemic circulation, where they do their job plugging the holes. So you have an explanation for the low blood count, the low platelets and the low white cells and the big spleen. And in the vast majority of cases, it doesn't need treatment, because it doesn't affect any of the function. It's just a consequence of the high of the portal hypertension, really, and it rarely translates into problems for the owner of that spleen. That's not true with ITP, where you may get a platelet count of 2 or 3. It should be in the hundreds, 150 plus. So very low platelet counts with ITP is a cause for concern and does need treatment and intervention.
Great, thank you. We've got a couple of questions coming in live about fatigue. Do we know why fatigue is associated to PBC, and do we know why some suffer more than others? Is there a correlation to other things?
The short answer to that is we don't know why people get fatigue. We know people with any form of chronic illness will get fatigue, and some chronic illnesses have more fatigue than others. We know that people with PBC have fatigue, and I think most hepatologists would believe that the fatigue you get with PBC differs from that of other liver conditions. There's no doubt they can be very severe. There is no question that the severity of the fatigue does not correlate with the severity of liver disease. You can have people with very early liver disease on blood tests and so on, and almost incapacitated by fatigue. So we know it's a real thing. We know it's not just sort of depression or pull yourself together type problems. It's a real condition that can have a major impact. We know there are certain changes in the brain and some in the muscle that correlate with the degree of fatigue, but that doesn't mean, which is chicken and which is egg, and it doesn't mean one causes the other. So there are a lot of potential reasons why people have fatigue. And one factor that I always think is telling is that after liver transplant, in the majority of cases, fatigue may improve, but certainly doesn't go away. So we don't transplant people for fatigue, however severe it is, not because we're not sympathetic, but because it doesn't make a lot of difference. There is a new drug that's being trialed, and some of you may be in the study. It's undergoing its clinical trial at the moment, and Mo's coordinating a lot of that. And
I was hoping to do a little punch for that at the moment, actually. Is that we are. So we're awaiting some further information from the clinical sites at the moment, just so that I can circulate that. But there was information in the last bare facts about that. And if anyone is interested about finding out any more about the trial, if they pop me an email, you can just send me an email direct. So it's mo@pbcfoundation.org.uk. And to anyone who's reached out already, you should have received an email from me to say that we're just waiting on the information, and I'll get that circulated. But there are a good number of sites around the country now, including one in Scotland, and quite a number in England, that we can get the information out now to patients. I'm just waiting on confirming that. So please reach out to me if you'd like to hear more information about that. So that's a study that's looking at fatigue and brain fog. There's another question here.
Sorry, Professor. The other thing just on the fatigue, which is interesting, it's the first time, as far as I know, that there is a drug specifically to treat fatigue. And one of the challenges has been, again, Mo's been instrumental in trying to solve this, is to measure fatigue. We can measure jaundice very easily. We can measure weight very easily. What we can't measure fatigue, and what the regulators need to know when you have a drug is, does it work? And that's why a placebo effect, because obviously fatigue is very subjective. We can argue whether you've got ascites, whether you're jaundiced or not. That's objective, but fatigue is like pain. Only the person knows what they've got, how badly it's affecting them, and so on. So the company have been very good in trying to work with clinicians to quantify fatigue so they can measure whether the drug works to an extent that people will say that the risks outweigh the benefits and the cost to the NHS is justified. So would you rather spend your money on treating fatigue or doing hip replacements, it's a difficult balance. So the study is the first trial of its kind in fatigue. It's taken a lot longer than we'd have liked because the company is being meticulous in doing it to do it properly, so we get the answers, does it work? But I think in the sort of short, medium term, it's starting to say yes, recognizing it's a real problem, looking at therapeutic options, and hopefully coming up with some treatments that, if it works, I think will be fantastic for so many people.
And a lot of our patients have already helped in the initial part of the study, which was designing the tool that you were talking about there. So we held quite a lot of interviews with patients so that a scale could be developed, so that questions around how bad your fatigue is, how bad your brain fog is, could be put together and used as part of this clinical trial. So we've had such a lot of support and help from our patients so far. But we are moving on to the first part A has also been done, which is testing the safety of the drug, and we're now moving into phase B, which is more longer term, looking at the dosage. So if anyone is interested in taking part, please just let me know.
And if I can just raise two other points, I know time is, but I raise which I can say, and I think you can't. Firstly, the foundation has been at the forefront of working with the company in developing the tool, and David Jones, medical director now, has been very much involved with the company, so that it shows the importance of the foundation. And secondly, without the support and volunteerism and altruism of the people with PBC, this wouldn't have gone so far. So it shows that the partnership of clinicians, patient groups, pharmaceutical companies can be highly effective if everybody works together and respects each other's point of view.
Yeah, and the company have been great in taking the patient perspective, and we've worked really closely together to do that. I'd have to say, it's a project that I've been working on since I started with the foundation, which is over 18 months ago now. It is taking longer than we'd hoped, but it's a really exciting trial that is happening and could make a real difference to patients. The other question I've got here is just around fatigue as well. So we've got a patient who was diagnosed in May 23 after bloods and scan. This last month, they've been suffering with back and side pain. Itching is driving them crazy, and also the fatigue is really getting them down. They've got an appointment next month, and they were just wondering if there's anything they should be asking their consultant. I would just say to make sure they're sharing that with their consultant and explaining their symptoms as well, so that their consultant understands what they're dealing with day to day.
Yeah, I think that's absolutely right. I think the itching is one thing, is separate. There are treatments for itching. They're not as effective as one would like, perhaps for a variety of reasons. And the itching and the fatigue are different. And the sort of thing I think would help is think and maybe write down, to aid your memory, give examples of how the fatigue is affecting you. What does it stop you doing that you would normally do to lead a normal life? Because I think tired all the time is a very common symptom that doctors get, and again, there are huge raft of reasons why. But I think if you can give examples to your doctor as to how the fatigue is affecting you, but the reality is there are some treatable causes of fatigue, like untreated thyroid disease, like some medication, and you have to exclude those. But if it's the fatigue of PBC, to be honest, there's not a lot that can be done to cure it, and the foundation can give you some useful tips gleaned from other patients as to how you can live with it, and Mo can answer that better than I. So the itching is different. There are treatments for it, and it's a matter of seeing which one suits you, and usually you can get on top of the itching.
If itch is interfering with your sleep as well, that can compound fatigue as well. So it is useful to see about getting treatment for itch if possible.
So do try and write it down and give examples. Don't go overboard. Just give the most serious ones, and then your doctor or nurse will have a clear idea of how it's affecting you. But as I say, at the moment we have no treatment to offer for fatigue other than sympathy and behavioral lifestyle and learning how to live with it rather than learning how to live without it.
I think even just discussing it with your doctor, though, and your doctor, it makes you feel heard in the sense of, yes, this is associated with my PBC, rather than if it's not discussed, you thinking, is it related, or, you know, how is this affecting me? I used to keep a small journal, but that was pre-PBC app, so you can actually record your symptoms in the app as well if that's useful. When you go into your appointment, you can look back and give some information that you might have recorded in the app around how your symptoms are affecting you. Prior to my transplant, when I was recording my symptoms, that was before the app was launched. And I just kept a little journal, and I just did exactly what you'd said there. I just took a note of it if it was something that really had a big effect on me that day. I think often when you get into your appointment, if you're thinking back, you might not remember it as well, but if you've taken the time just to jot it down as you're going through your weeks, it's a good point of reference to go back to as well.
And also go, if you can, go with somebody, because 2 pairs of ears and 2 mouths are better than one.
Yeah, and I used to joke, my husband always came with me, and we had a little list that we would prepare in advance, and then we would chat about it on the way home, because you're right, there was things that I would take from it that he would take different. There's also been occasions where I've forgot something and he's mentioned it before the end of the appointment as well. So I think that is really important too. So I'm just going to answer a quick question around how we get the app. So someone's in Australia asking about the app. I'm not 100% sure about Australia specifically, but it should either be in the Play Store or in the Apple Store. But if you have problems with that, just reach out to us direct and we'll give you some information on that. I just would like to say that there's been a couple of specific thank yous for you, Professor, that are coming in the live chat today, just to say thank you for explaining it so well and your understanding around some of the questions that we've taken today. So it's really important that I pass that on to you. So
that's kind. Thank you.
So I'm just we've still got some questions that are here in the document, but I'm also just having a wee look to see if there's anything that's came in live that we could potentially take just now as well. I'll take one from the list just now. So there's a couple of questions around URSO. So a patient who takes their URSO 3 times daily, which is advised with food and water, they're asking if it's sufficient to have, say, a banana with that, or if they should be thinking about having a bigger meal when they're taking their URSO.
Yeah, there's a lot of discussion about how you take the URSO. My own approach has always been to advise saying that once a day is enough if you take it all in one dose. 3 times a day can be done. Some people take it in divided doses with food because you get fewer side effects, you get less bloating and so on. So the important thing is to get it past your lips in a comfortable way. There are very few things, as far as I'm aware of, that prevent its absorption. So if in doubt, talk to your pharmacist or doctor. But my own feeling is it doesn't matter too much how you take it, provided you take it on a regular basis. Mm-hmm. And whether you take it when you put your teeth in the morning or when you take them out at night, I personally don't think it matters terribly. But talk to GP or more importantly, perhaps your hepatologist, and see if they have any strong feelings. But my own approach has been, just take it. And if you're taking a tablet 3 times a day, it reminds you all the time of it. A, it's much harder to take because you have to, you're going out, you have to take it with you. And B, it reminds you that you'll become a patient, if you will. And it's far better, let's say, if you take it just when you do your teeth or whenever. And that's another reason why I used to recommend people take it once a day, but talk to your doctor and nurse. I don't think it matters terribly personally, but check with them But the main thing is to get it down neck, as they
And
say.
I think if you're taking it once a day, the routine gets in quicker, doesn't it? And then you're more likely to remember. There's a question that's come in live that I'd like to ask, and it's from a patient who's asking if you have high risk PBC and are put on third line treatment, so it's urso, bezafibrate and OCA, and your LFTs go into normal range, are you still high risk and will progress quickly?
That's a very good question. My initial thought is probably sort of a slight fudge. Yes, you're high risk, but the risk has been averted. And
especially being back into normal range, which is great, even,
yes,
you know.
And so I would still consider yourself somebody with an aggressive form of PBC, but the treatment has become effective. One of the conditions about PBC, it's for most people, it's a very long-term condition. If you have something like meningitis, you either get better or not very quickly. With PBC, many, as we said before, many people will go to their graves with PBC, but certainly a higher risk. I would bet that yes, you're high risk, but you've reduced that risk. But obviously, taking 3 lots of tablets is quite an undertaking for anybody. But the reason why you're on triple therapy is to turn you from a high risk to a low risk patient. The fact your liver tests are normal carries a very good sign, and come back in 30 years and we will confirm that, or maybe 40.
And the good thing is that having more second line treatments available so that people can be on triple therapy or what's needed. We've got 2 other in the pipeline as well, which is great news, because that'll help patients who are not responding to urso or potentially OCA as well. So that's great. There is such a lot happening in terms of clinical trials, treatments for both disease progression, but also symptoms as well. And that's something that we're hoping to update on our patient conference that we're holding next September, in September as well, over PBC Day weekend. So it is really good to see that there's so much activity in that area, which is great. I think that's us getting to a close for today. I didn't get through all the questions that have been sent in, but I will hold them over for our next session. And I will say that I was just doing the diary with our doctors for the next few months, and I put a request out on Sunday evening to our doctors to say, could you let me know your availability for our Q&A sessions? And by 4:20 on Monday afternoon, I had every session booked till the end of the year. So our doctors continue, along with yourself, Professor, to give us their time, and we really do appreciate it. Our Q&A sessions continue to be as people enjoy attending these. They're able to give in their questions to us. They remain to be as popular as ever, and certainly one of the highlights of my week. So if we haven't got to your question this time, please know that I'll hold it over for next week, and I'll also pick up any questions that came in live that I haven't been able to ask in the session today as well, but we'll make sure it's added to the list for the next time. Thank you so much for your time today. I would like to add my thanks to the patients who have been giving it to you today as well, just to say thank you. We do appreciate the time you take to explain things in a bit more detail as well. I think that's really useful for patients to hear, so thank you very much.
Well, no, thanks. I mean, the reason why all the doctors are happy to give their time is because they see the value and recognise what the foundation has to offer, and the need for doctors and patients to work in collaboration. So we do it because, it's a good thing.
Yeah, and we really appreciate
the patients for joining in and asking the questions.
We are never short of questions, never ever are we short of questions, which is brilliant. So thank you so much for your time today. Thanks, and I look forward to seeing you again soon.
Okay, take care, everyone.
Take care. See you later. Bye.